This is where I'm going to disagree with conventional cardiology that say, well, genetic risk factors are non-modifiable. Genetics is non-modifiable, but genomics is highly modifiable. And that's, I think, where we need to go.
Welcome back to the Rethink Aging podcast. Today, I have the pleasure of sitting down with my colleague and friend, Dr. Regina Druz. Dr. Druz is an integrative cardiologist, healthcare innovator, educator, researcher, and founder of Holistic Heart Centers, where she combines precision cardiology, functional medicine, genomics, and lifestyle medicine to help people optimize both longevity and quality of life. She trained at Cornell Medical College, is board certified in cardiology and advanced cardiac imaging, and is certified through the Institute for Functional Medicine, and has become a nationally recognized leader in precision cardiovascular care. But what I appreciate most about Regina is her willingness to challenge conventional thinking and continually ask deeper questions about what truly creates health. Dr. Regina Druz, welcome to the podcast.
Cindy, thank you so much for having me. And I'm super excited to speak with you, especially considering the work that you're doing in brain health arena, longevity. I'm pumped for this conversation to take place.
Super. Well, before we dive into the science, I'd love for our listeners to get to know you a little more. Tell us your story. When you look back on your journey, what has made you into the physician and the person that you've become today?
Oh, that's sort of a fairly deep question.
Mhm.
Physician and a person. Well, I did not come from a family of doctors. Actually, my parents were not doctors. They were engineers. They were sort of, more technical in nature. My aunt and her daughter, my cousin, were physicians and they were OBGYNs. And very early on, they became my role models because I think what was so attracted to me when I was, literally just a kid is that both of them were these very powerful women. They had this energy that could change the world. And whether it was a small slice of that world in a city where we lived or the world at large, it didn't really matter. And they were changing people's lives. They were saving women who had issues, obviously, during childbirth or pregnancy. They were there on the front lines making things change. And so that shaped a lot of my views. I decided to become a physician. And when I picked cardiology, my cousin called me and said, "Are you nuts? You, this is who picks cardiology as a woman?" And I said, "Well, I do because I kind of like it. I like the heart. I like it's so phenomenally designed that nothing in the heart is extra. Everything serves a function, and in harmony, it powers the entire body." And, I've been a cardiologist since, let's see, I'm going to date myself, 2001. I evolved as an integrative cardiologist, following mid-career crisis, which is, probably a very common story. But it wasn't really a professional crisis so much as it was a personal crisis. I noticed some changes in my health, and that sort of started clicking things for me. And eventually, these clicks formed a path, and here I am traveling in this path as an integrative cardiologist and longevity doctor. And I do appreciate you saying that I am not afraid to challenge conventional wisdom. And that's exactly what a lot of it is not only challenging conventional wisdom for the sake of challenging it, but really prioritizing our patients, really making sure that a person in front of us get the best possible solution to their problem even though there's a lot of noise out there, really becoming their partner in that health journey, and taking them to successful health transformation, whatever it may be.
Hmm. I love that. And yes, deep respect for choosing a male dominated, very rigorous field. And, the deep training that you've had in conventional cardiology. I'm curious if you recall, was there a particular moment or moments where you began to start questioning the conventional model of cardiovascular care?
Yes, there actually was, because I actually distinctly remember it, which is funny because there were two such moments, right? So one moment was when I was primarily hospital employed for kind of the first half of my career, sort of rising through these academic institutions. And in one of my roles, I was leading the section on cardiovascular imaging. It was a specific type of cardiovascular imaging. So I'm cardiac imager by training. That's my first love, which you'll never forget. You always come back to it. And so my section specifically focused on something called stress testing. And at that time, majority of that stress testing in my area was actually done using radioactive nuclides, which is still done until this day. It's a very common type of testing. And so we had an incentive, or an initiative rather, at that time, to really help our colleagues in the emergency room to allow patients to get exercise tests so that they could be discharged. So if a patient comes in with chest pain, for example, and we want to know, is it safe to send them home? Their blood work is fine, but we want to know the status of coronary arteries. And so we would essentially bring those patients in as quickly as we could, get them exercise, typically treadmill exercise, and if the test was normal or near normal, we would safely send them home, right? And so when this happened, we started seeing multiple patients that potentially were not coming to us before. And a lot of them were young, right? They were on the younger side. And as well as I do, you being a longevity doctor yourself, that one of the most important determinants of longevity is that ability to exercise, our oxygen
Mhm.
consumption. So ability to achieve something called a certain VO2 max. And, there are these norms for age and gender that, in plain English, it means, are you able to get on the treadmill? Are you able to last 5 minutes of
Mhm.
this treadmill exercise? Because it's very specific. The machine starts, then it goes a little faster, the angle increases. So these 5 minutes are sort of the critical time when we can say, hey, this person is not at high cardiovascular risk, or this person is, because they could not finish those 5 minutes. And I was shocked at the amount of individuals, young individuals, where talking 30s, 40s, early to mid 50s, the type of age strata where we wouldn't necessarily say that these are old people. These are not old people, right? These are much adults that's supposed to be in peak health. But a lot of those patients weren't. And they really, even if they could complete 5 minutes, which is sort of like the barest minimum, they did not measure up to age specific norms for their age and gender. So they were not physically, it wasn't just the conditioning, it was that their cardiac capacity wasn't great. And so that sort of started me thinking is that, why are we even doing this? Like, what are we missing, right? Why are these patients in the emergency room? Why are they being told that they have high blood pressure and high cholesterol? What is missing from this whole schema that, they don't have a doctor, they get to the ER, we find a bunch of cardiovascular risk factors. If we put them on a treadmill, they can't really show us that they have good exercise capacity, which is so important for longevity. What are we missing? And that was sort of like this aha moment, but it was a scary moment because I didn't have an answer, right? I did not know what we were missing. I was conventionally trained, and I still believe that the best integrative cardiology is the one where you bring the best of conventional medicine and holistic approach to really find the true solutions for your patients. But this aha moment was very scary because I also at the same time had other people that were getting a stress test, and those were much older people. We're saying 70s, 80s. Not all of them were able to do treadmill exercise, but some were able to. And some of them, surprisingly, had very good metrics. And so here we had this dichotomy: younger persons who were not able to do even average for their age, older persons who were able to do much better than their age. They didn't necessarily have treatable heart disease. They may have had risk factors. So I had to ask myself, what is guiding this, right? What is it? And so I went to a conference. I still remember it was American Academy of Anti-Aging Medicine, or A4M. And at the time, they were offering these modules, and I think they still do in various areas. And at the time when I went, it was the last module in cardiovascular sequence. I did not take one, two, and
Okay.
three. I just ended up in module four. And so I went into that module four, and Dr. Mark Houston was there, and he would
Mm-hmm.
ask, questions of the audience. And once in a while, I would give a response. And so during the break, he'd pull me aside and he says, "Who are you? I don't remember seeing you in my other modules." And I said, "Well," I said, "I'm so and so. I'm a cardiologist." And he speaks with this sort of like Southern, droll type of an accent. And he looked me straight in the eye and he said, "Regina," he said, "once you drank the integrative medicine Kool-Aid, you will never look back." And he was so right, because I sort of thought to myself, I'm highly trained, highly boarded, and I work in an
Mhm.
academic institution. Now that was Friday. I came back on Sunday. I went back to work on Monday. And all of a sudden, I was not able to see patients the way that I used to. I would still do, of course, my conventional workup, but the why of what's happening to them was pulling at me. And that was sort of the beginning of this journey. The moment or moments that open the doors and say, "Hey, you have to walk through them now, because that's the only path for you." And I guess that's what I do.
Oh, well, I am so grateful to get to hear your journey, and I'm grateful that you got started on that path. And I agree. One of my mentors had a saying, once you see, you can't unsee. And it's so true. You can't ever go back just to that conventional box of thinking when you see the deeper root causes and the power in prevention. It's just so critical. And one of the reasons I'm so excited to have you here is because, of course, my focus is on cognitive decline prevention, and your focus is on cardiovascular health. And as you know, those are really two sides of the same coin. And we have a saying, what's good for the heart is good for the brain, or what's good for the brain is good for the heart. I would love to hear your explanation of why that is. What is the, connection there?
I think this is an extraordinary point that you're making, Cindy, because, we are, I think, transitioning right now from just having these siloed specialties to really recognizing that there are common root causes that are driving changes, not only in the heart, not only in the brain, but also in our kidney and in our ability, for example, to even kind of prove ourselves against other non-communicable chronic diseases, such as cancer, for example, right? So, the problem is, or maybe it's not a problem, maybe it sort of gives us a solution, right? The opportunity is that these fundamental root causes are driving dysfunction in brain health, are driving dysfunction in heart health, driving dysfunction in kidney health. And one of the ways they're doing that, sort of the final common pathway, if you will, is actually vascular. And this is why I always tell my patients and I tell my colleagues, longevity is vascular. You could look great, you could have a perfect body composition, but if your blood pressure is not regulated, if your if there is inflammation in your blood vessels, if your blood vessels are leaky, if metabolically your lipids and your sugar are not in a good place, then you are not really walking the path of longevity, right?
That's right.
Right? That's where longevity starts. So, so what are those factors that are so powerful that are, sort of drive the train of brain dysfunction or impact brain health, impact heart health, impact kidney health? Metabolic factors always emerge to the front, right? So, metabolic rigidity, insulin resistance, and obviously diabetes, sort of the end stage of these processes, are the most powerful drivers that are affecting us. And I think we are sort of seeing a real life proof of this assertion because of the success of the new medication classes, like the incretins, for example, right? So Ozempic, Wegovy, Mounjaro, tirzepatide. I recently did a little bit of a literature review, and it's clear from the accruing body of evidence that these medications are not just delivering the impact because of the weight loss, because in some of the studies, the findings that translated into improved vascular outcomes were independent of the amount of weight loss achieved, right? And so the sort of thinking is based on some of the studies that are done is that there is a direct impact on cardiometabolic axis. And this is where these medications are delivering their impact. And so it confirms what you and I know from our functional medicine training, right? That this cardiometabolic dysregulation is at the core of chronic diseases. And of course, how does cardiometabolic dysregulation exerts its effect? Well, it's primarily a vascular effect in a number of ways, because even the visceral fat that typically is something that we looked at with cardiometabolic issues and insulin resistance, for example, we're now learning from advanced imaging studies that this type of fat doesn't only deposit, for example, in our abdominal area or in our liver. It actually builds around the heart, around the coronary blood vessels, and it is metabolically active. It sends inflammatory signals into the adjacent tissue and plays a role in heart disease, in diseases that have to do with structural changes in the heart muscles, such as atrial fibrillation, for example. So there is a lot of opportunity, I think, right now for your listeners, my listeners, and our patients to realize that the core is cardiometabolic. Now, and once you understand that, everything else makes sense because inflammation plays a huge role. Inflammaging is one of the hallmarks of aging, but you will almost always get into inflammatory state if your cardiometabolic issues are off balance, and that then becomes a compounding effect, right? And the same is true for oxidative stress, and the same is true for hormonal imbalance. So while each of those buckets, if you will, root causes, they are highly important in driving chronic diseases. If there was only one that your listeners would say, I must know what is happening with me right now because I want to protect my brain, I want to protect my heart, I want to protect my kidney. If they were picking the top contender, that would be the cardiometabolic contender, right? Insulin
Mhm.
resistance and everything that follows.
Yeah. So good. I'm excited to be able to share this link with my patients and when we have the discussion about, well, your blood pressure's 148 over 92 today. Oh, doc, that's just white coat hypertension, and it it is so critical, the health of our vascular system and the endothelial lining, not only for the heart but also for those tiny blood vessels in the brain. And so this will be part of my plea to my patients to take their metabolic health seriously.
And a lot of those patients who may be experiencing labile blood pressure or even new onset hypertension the reason why they're there is because their cardiometabolic health is not optimal, right? So we
Hmm.
know that there's a strong link between insulin resistance and elevated blood pressure, and again, it's that
Yeah.
compounding effect that is taking place. So so definitely, share this little pearl that hopefully will help people to turn things around.
Yeah. Well, you often use the word precision cardiology, and I'd love to give you, a platform to just define that, help us understand what that means to you and in your practice.
Thank you for doing that. So, precision cardiology, in many ways, we could use the same definition that precision medicine is using, but I think it is a bit different in the context that we're using at the holistic heart centers because we are really positioning all of our tools, diagnostic tools, treatment tools, or interventional tools to be precise based on a given patient's physiology and unique characteristics, right? And so this is where precision comes into play because what we usually get in a standard clinical exam could be a measurement of blood pressure as you are doing as well and your patients are doing as well, and some blood work. This is very common. Sometimes this blood work is a little bit more standard, and sometimes it's a little bit more advanced, includes a lot of biomarkers. But is it really precision medicine? It is not, because precision medicine is really trying to figure out an individual genomic and phenotypic makeup of who our patients are so that we can position our interventions appropriately. Because we have to recognize that what we see and what we can measure in the standard clinical domain is really not optimized for our individuality, right? It's optimized for larger groups of patients, sort of putting patients into buckets, if you will, right? And in many ways, we're practicing this population level medicine, trying to fit, was it a round peg into a square hole,
That's
right?
right.
Right? Trying to apply it somehow to a patient in front of us, right? But there are, luckily, because of the advances in science, advances in genetics, the role that artificial intelligence has begun to play right now, we are actually able to go much deeper. So, part of that precision cardiology is really having a pathway that looks at various facets of person's cardiovascular health makeup. And as we said, it affects the brain, it affects the kidney, it affects the entire body. So we'll look very thoroughly at genetics. We'll look at advanced biomarkers. We'll look at oxidative stress. We'll look at toxic burdens. And we sample along the way what impact have these factors or root causes exerted on someone's vasculature. So you mentioned blood pressure, and actually, blood pressure is just the tip of the iceberg because some of the earlier changes, like changes, for example, in arterial stiffness of an individual, something that we measure for most of our patients, are increasing their risk sort of decades before they actually become hypertensive, right? So, this is what precision cardiology is about. It is figuring out specific areas that we know play a role in cardiovascular health, play a role in longevity, play a role in brain health and kidney health, because essentially there's heart brain kidney connection, which is
Mhm.
undeniable, right? And I'm sure we can plug the gut somewhere there along those
Right.
axes, right? But figuring out what is individuals' state in each of those areas, because these areas are all critical to disease development, and these areas are all modifiable. And even when sometimes patients come in and they're a little bit, um, I'm not going to say they're not confused, but they're a little bit unsure as to why genetics is even necessary, because they perceive genetics as something that is fundamentally unchangeable. And what they're not understanding is that we're not attempting to change anyone's genetics, although there are companies right now that using CRISPR technology to cut off some of the genes. But what we are trying to do is to influence genomics, which is the impact of environment on person's genes. And knowing what that genetic predisposition is, what that blueprint is, gives us an opportunity to influence the genomics right. Right, because we need to know what's under the hood in order to tell you what needs fixing, right? And so that actually creates a huge opportunity. In the studies, for example, that were done that looked at the impact of genetic testing. Cardiologists used to think that some people, it's a minority, maybe 1 in 300 or so, have a very large impact genetic variants that are associated with something called familial hypercholesterolemia. Those are patients who, if they have two variants of a culprit gene, they may have sky high LDL cholesterol from a very young age, or if they have just the one copy as adult, they will not necessarily have it sky high, but they will have, let's say, LDL above 190 and it's very persistent. And that sort of would say, well, this probably is a genetic factor. But the thing is that this particular abnormality affects 1 in approximately 250 to 300 individuals. So it's quite rare. By the same token, we know from the large biobank studies that majority of atherosclerosis is actually not driven by those big impact. I call them with my patients. I call them big bad genes, like big bad wolf, like big bad genes. No, majority of impact is not driven by big bad genes. Majority of impact is driven by a combination of genetic variants that have much smaller impacts, but when combined together, they could potentially set a person to be in the highest risk group. So anything, let's say the highest 20%, the highest 10%, based on the combination of these genetic markers. And this is called polygenic risk score. And depending on how you slice it, let's say if you're going for that, let's say you're going for this top, 20%, you may find that this is present in 1 in 20 individuals, not 1 in 300. That's an order of magnitude, which is 15 times greater than the big bad gene, right? And it shouldn't be missed because the study just came out a few months ago from I think a Mass General Hospital, where investigators offered patients in those high risk groups genetically. They did not have any heart disease whatsoever. They were not treated for heart disease. They were fairly young individuals, but they had the genetics done and they were determined to be in that top 20% based on this polygenic risk score combination of genetic markers. So what investigators did is that they invited these patients for free to come and get an assessment to see if they had any plaques in the coronary arteries. It
Hmm.
was open to people in the trial, and whoever showed up, they basically got a free scan. And so they scanned approximately 200 or so individuals, young people who had no symptoms, people who, by traditional risk estimates, all of our population based equations, were in a low risk group. So you would never really treat them with anything. You would just tell them, keep a healthy lifestyle. And they discovered that 50% of those people had soft plaque already,
Hmm. Hmm.
right? So
Yeah.
if you give them another 10 years, 20 years, 30 years, they become our patients, right?
Yeah.
They drive the heart attacks and the stents and the bypass surgeries. So the precision cardiology is not only about recognizing that root causes in a population based framework are grossly underestimated, but also starting much earlier in individuals' lifetime. And people often ask me, well, when would you start? And they'll say, start in childhood, start when
Yeah.
somebody is at least 18 years of age, right? Because you want to respect you want to give a person the best chance you can at preventing lifelong disease because you know it's going to affect their heart, their brain, and their kidneys. So there is never not a perfect point to start, right? The sooner the better.
In utero, as a family doctor, I think about
Yes,
the
in
mother's
utero.
impact on the health of the baby in utero and throughout childhood. Oh, I love hearing your perspective on how genomics can, influence prevention in a much bigger way than traditionally has been thought in cardiology. And similarly, in my practice, there are the big bad genes with Alzheimer's disease, the autosomal dominant, the presenilin 1 and 2, and the amyloid precursor protein mutations that lead to early onset Alzheimer's disease pretty, reliably throughout each generation. And of course, those are, terrible mutations. And, there's the more common ApoE4, the quote, Alzheimer's disease gene, although I'm sure you would label it cardiovascular disease gene as well. But there are so many other genetic SNPs that influence brain health. And so there's a parallel here in the cognitive decline prevention world. So I love hearing your perspective. And I'm sure a question on our listeners' minds is, say I do have some genetic risk. Can lifestyle, can functional medicine, can precision cardiology overcome some of those genetic risks?
Absolutely. And I think this is what, I want to really sort of transmit this message as loudly as possible is that genetics is not a person's destiny, right? The very famous saying that we hear multiple times is that genetics loads the gun, environment pulls the trigger.
Mm-hmm.
Not that I'm very happy to give a gun reference, but
Sure.
but in general, you get the idea. And so I think genetic makeup is a huge opportunity. We have patients, for example, who are young patients, they're very healthy, they are struggling to normalize their lipid parameters. And they've been trying various things, and sometimes they're successful, but only modestly so. And sometimes they're hugely unsuccessful because they shift their diet in the wrong direction without knowing their genetic makeup, and their numbers are off the charts. And so our opportunity with genetics is to unlock the information that we need in order to create this genomic improvement prescription, right? What kind of diet, what kind of supplementation, even what kind of medications, what kind of exercise, what is it that needs to be done in order to mitigate the impact? And thus, had actually been quite successful. We had seen patients following this strategy to really achieve durable reductions in their lipids and reverse their sort of what's called atherogenic lipid profile, reverse it completely, often without medications, just with the combination of lifestyle and supplements. And for some patients, medications are absolutely necessary. They play a role. And I think genetic information also gives us this opportunity to understand which medications and why may be of value, right? And you have exact same thing, I think, in brain health, just as you mentioned. The ApoE is a very special character because it sits at the crossroads of cardiovascular and neurodegenerative paths, and it works, through abnormalities that we can measure, which is lipid abnormalities, and so it's absolutely fascinating, and hopefully a lot of future work will give us even more information than what we have today, because it's such, as you mentioned, it the adverse, ApoE alleles are present in about 25% of the population. So that's huge chunk of people that potentially have this. And, genetics is modifiable. This is where I'm going to disagree with conventional cardiology that say, well, genetic risk factors are non-modifiable. Genetics is non-modifiable, but genomics is highly modifiable. And that's, I think, where we need to go.
Super. Well, speaking of the future, and you are at the cutting edge, I would love to hear your perspective about, what are you most excited about in the future of precision cardiology?
I have to tell you that I'm a huge, AI enthusiast,
Uh-huh.
having, developed some of my own AI applications. I'm what they call a vibe coder, for what's that worth? I'm vibing with the machines,
Okay,
but
okay, I
but
get it.
that's what that means. But I think that's the most exciting opportunity because I think once we really are able to leverage the artificial intelligence as a partner, and it is entirely a partner, we will discover new things and new venues and get fresh insights that have not been available to us before. If you think about it, when a patient, let's say, goes to a physician and they get a specific advice related to their issue, they're getting experience and expertise of this physician. But what if they were able to get experience and expertise of 100,000 physicians, or who have treated the same type of a problem, or outcomes of 1 million patients who have presented with similar circumstances? This is that power that we need to figure out how to use it to benefit our patients. And, one of my products is called Hartwell.ai. It's a product for professional use only. So, if you
Nice.
list,
Okay.
yes,
I'm gonna
yeah,
write
if you
that
list,
down.
write it
Hartwell
down, Hartwell.ai.
dot AI.
Yep.
Okay.
If your listeners are listening, they could invite their physician to sign up. We actually have a free tier as well. And so, what we're doing in that Hartwell.ai is that we are creating personalized cardiovascular risk. We're taking all of the standard equations that are endorsed by American College of Cardiology and European Society of Cardiology, and we are putting in genetic and genomic information. We're putting in cardiac imaging information, and we're simulating the impact of medications and supplements, not only on cholesterol, but on global cardiovascular risk reduction. And so I think that's the opportunity that just a little, entry level opportunity that AI affords us. And I think as we go forward, we're going to see more and more of that. NVIDIA, I read recently, is actually building a medical large language model with Mayo Clinic. So we're talking about millions of data records, right? That we as physicians and our patients will be able to plug in. And so I'm excited about it. I think that's going to help people like you and I to bring our methods to the surface because, we've been walking in that integrative medicine, functional medicine lane. And, there's some criticism that comes, of course, because we don't run randomized placebo controlled clinical trials. But I don't think we're going to need these trials as much anymore because we'll really have the data speak for itself.
Yes. Oh, I love that. So exciting. Thank you for sharing that perspective. I'd love to shift gears a little bit. You and I have talked about stress before in the past, and I'd love to just explore how stress impacts our cardiovascular health and any insights that you've gleaned in your training and practice around stress and how we can modulate that and help improve our cardiovascular health.
That's a tough one.
It is.
It's a very tough one, and you're so right because even the cardiometabolic imbalances that we often see, one of the common culprits is stress, right? It's not uncommon for us to find insulin resistance or markers of insulin resistance trending up in patients who are experiencing stress, and sort of the often comes with stress is sleep disruption. So I think we can't exclude it, right? They're kind of travel together because when people are stressed, they tend to sleep less. And when people sleep less, for example, if they have sleep apnea or they have disordered sleeping, their body is under physiological stress. So I think stress is a really powerful factor. It's a difficult factor to address because I find that with my patients, addressing stress often requires very significant changes in their lifestyle, and not everyone is willing to do these changes, right? Because it essentially really requires people to change what they're doing and how, and it's really not enough to say, oh, go take a break or go take a vacation, because these periodic de-stressing periods are not likely to influence or to win over a situation where a person's daily life is highly stressful. And what I find challenging is that we tend to adapt to it and becomes our new norm. So we don't even know what it feels like not to be stressed, right? We are constantly multitasking. We're constantly bombarded with negative news. We constantly try to go in all directions at once, and that makes it super challenging. So, we have a program at Holistic Heart Centers, which is multifaceted. It does use digital markers. So we monitor quite a bit with various common things, things like Aura Ring. Some people like another wearable called Whoop. And we'll look at heart rate variability. We'll look at resilience. We'll look at stress recovery, because we now, as I mentioned before, we have the data, this data that each individual could use for themselves. And if they're willing just to take a chance and do a little experiment, and let's say when their Oura Ring tells them that their HRV is dropping, and they've been, and ask them to pick something on the list to that maybe be an explanation. If they're honest and they're picking the honest contributor, that's that first step that one needs to take in order to figure out how to make these lifestyle changes. And then these big lifestyle changes that I, always feel like my patients should be making, but they're so difficult because they're so large, then they become much smaller incremental
Yeah.
steps. And
Mhm.
it's possible, so it's much more likely that a person will execute a small incremental step as opposed to change their entire routine at once, right? So I think that's where the opportunity is with this type of personalized technology, is really giving
Yeah.
people these point solutions that are good at this moment in time, because this moment becomes thousands of moments and hundreds of
Mhm.
days and many years. And so again, that compounding effect, goes through if people are not making those changes.
Super. Well, we are definitely in alignment with that. I've got my Aura Ring and, monitoring all those parameters on myself and
Ordering
see
buddies.
that um, for the sake of our patients and listeners, can you just share a bit about how stress im impacts our cardiovascular system on the endothelial level and
hmm
micro and macro level?
Yeah, so great question. So let's go with the macro level first, because that's what people most likely will notice in themselves, right? So when we're stressed, we tend to have increase in our heart rate, and this is commonly referred to as tachycardia. Sometimes, if people are prone to certain types of cardiac arrhythmias, which means disorders that are not a normal heart rhythm, they certainly could be induced. These episodes could be provoked with stress exposure. For example, atrial fibrillation could be provoked with stress exposure if somebody already carries this diagnosis, and sometimes even for the first time. But typically, we would see increased heart rate, we would see increased blood pressure, and in cardiology, we could multiply a couple of numbers by each other, usually your systolic blood pressure and your heart rate, and we call it increased or double product, right? Now, you may say, well, it's not necessarily really bad, because when we exercise, we produce the same. Our heart rate goes up, our blood pressure goes up. But when we exercise, we then go through the period of recovery where those things stabilize. When we're stressed, we may not go through the periods of recovery. The stress could actually be chronic or chronic and repetitive. And we begin to see it because our heart rate variability, which is a tiny variability between the interval of two consecutive heartbeats, the faster is our heart rate, the lower is the heart rate variability. So when it starts to trend down, we know that this is a marker of stress. It could be psychological, it could be emotional, it could be physiological. maybe pollution, maybe all of the above, right? And so that, of course, has a negative effect on our system because obviously, if it happens frequently, if the heart rates are frequently elevated, the blood pressure is frequently elevated, we know there's end organ damage, right? There is changes in the kidneys, there are changes in the brain. We see this white matter disease type of deposition situation. There are changes in the heart muscle becomes what's called thickened. It's a medical term as hypertrophy, and potentially could even lead down the line to highly undesirable heart disease states such as heart failure, for example, right? So that's sort of the macro level. On the micro level, we know actually from the studies in patients who have survived myocardial infarction, there were some really elegant studies where those patients had imaging, but the imaging wasn't the heart imaging, it was imaging of the amygdala in their brains.
Oh,
Okay.
interesting.
And
Yes.
yes, so of course, amygdala, our sort of, emotional center that makes us feel fight or flight or very stressed or maybe relaxed. And so what was noted is that after the heart attack, obviously a heart attack is a painful event, it's a very traumatic event. Investigators found that while the patients were treated cardiovascularly, they had a pattern in their amygdala on PET scans that showed intense activation. And when they measured the impact, well, what does that intense activation mean? Because the patients haven't necessarily said that they were feeling unduly stressed, right? This was just the imaging finding. Investigators also determined that this activation of amygdala initiates a neurohormonal cascade that mobilizes our first responders, which are immune system cells, that then go into the vasculature and start remodeling coronary plaque. Right. And they specifically home in to the area that may have been affected by a recent infarct, and they could potentially either heal the plaque or, unfortunately, perpetuate the damage. And this is called echo effect, right? So what happened in the brain echoed in the heart. Very elegant study done with, sort of, very sophisticated imaging, but it essentially showed us that no, it's not all in people's heads. When it is in people's heads, it's also in their hearts and probably in other organs. And this is what you are essentially alluding to: endothelial dysfunction, recruitment of smooth muscle cells to proliferate in the arteries, and even that. While these are molecular mechanisms and they have sort of various pathways and feedback loops, the propensity of an individual uh, to have disrupted endothelium or to proliferate those smooth muscle cells that are components of the plaques is also genetically driven, right? Some of the most common genetics for heart disease is not for cholesterol. It is exactly for this, right? And so you could see that, individuals who are chronically stressed or stressed, sort of repetitively, maybe it's not a chronic stress, but it's a repetitive exposures, they have accelerated coronary artery disease. And we know this, for example, we know this from individuals who experience adverse childhood events. Right. We know that these individuals have increased rates of chronic diseases, specifically coronary artery disease, accelerated atherosclerosis. Any type of adversity in early childhood will actually do that. So, there are models of this. And so then, we even know I see a lot of sort of effort in the traditional or conventional cardiology and conventional medicine to understand the impact of high cortisol. So, we're sort of seeing conventional medical colleagues recognizing that high cortisol exposure is something that continues to drive hypertension, that of course drives brain disease and heart disease and kidney disease. And we've known about this in functional and integrative medicine for a long time, right? That the impact of fight and flight response and disrupted cortisol curves and, conditions of both very high and very low cortisol are unfortunately positioning people for diseases of which accelerated sclerosis is one of them.
Okay, well, super. Thank you for that elegant, in-depth exploration of how stress impacts our physiology down to the lining of our blood vessels. So enough about stress. I want to have a little fun here to wrap up.
Stress. Let's take a deep breath. So we're not stressed. We are
Yes.
grounded.
Yes. Well, I'm going to put you on the spot and ask you a few rapid fire questions, just fun stuff. Answer the first thing that comes to mind. Coffee or tea?
Green tea.
Mhm. The most underrated health habit.
Community.
I love that. Yes. One supplement, nutritional supplement that you think deserves more attention.
Omega-3s.
I concur. The most overhyped health trend right now.
Oh God, peptides.
Okay. The Wild West. Yes, I agree. One book that has influenced you.
Does it have to be a health book or any book?
Any book. Any book.
Actually, the book that most recently influenced me, and I read a lot and mostly listen on Audible, is Let Them Theory by Mel Robbins.
Let them. Yes. It's a good theory of release and surrender.
I'm applying it consistently.
That we're not in charge of the universe,
Exactly.
orchestrating everything. Morning person or night owl?
Night owl.
Yeah. Favorite way to move your body?
My dance class.
Yes. What kind of dance?
So it's a contemporary dance, and we have a great instructor. I've known her for over 10 years, and she just makes it fun. And we don't just dance; we're a community of dancers, which is a lot of fun.
I love that. If you could eliminate one thing from the standard American lifestyle, what would it be?
Sleep disruption.
Yeah. Sleep and stress, yes. One thing you wish every medical student would learn.
Take care of yourself first.
I got that advice when I was a college student, and this female physician was so compassionate and concerned for me, and I was oblivious.
Of course.
What's she talking about?
Yes, you're young and invincible.
Right. Oh, goodness, Regina, I would love to know a bit more of your personal longevity plan. It's my favorite question I get to ask on this podcast. So you spend a lot of time studying cardiovascular health and prevention and longevity. If we secretly followed you around for a week, what things are you doing to take care of yourself and protect your body?
It's funny that you're asking it, because I was thinking the same thing, right? We always try to figure out, am I doing enough? Am I doing too little? So I think the number one accomplishment over the past few years for me has been that I managed to reverse my constant stress exposure. I made changes that were lifestyle changes, professional changes. There were hard changes to make, but I think it worked to my advantage, because I was, sort of feeling constantly stressed, and I knew I was constantly stressed, and so that helped me quite a bit. The second area where I'm focused right now is sleep, because as most women know, in perimenopause, menopause, we start getting disrupted sleep. We start getting components of sleep apnea, so that needs to be addressed. So that's part of my longevity routine, to optimize my sleep. I am very committed to exercise, so I'm in the gym 3 to 4 times per week. Combination of weights and aerobic activity. I am very committed to building a community of wonderful friends like you, my other friends, my family, and really being there for the people because, I feel like that gives me purpose. And when somebody annoys me, I just say, let them, because that's my application of Mel Robbins' theory, you know. And last in this sequence are supplements. I am, obviously nutrition and supplements. So my nutrition
Mhm.
overall is pretty clean. But, I do believe that advances in science, not only in supplements, but also in medications, have opened new opportunities. So I do personally use Zepbound for a variety of reasons in standard doses, because of some of my medical history and just, it is what it is. And I think that is a great opportunity for longevity, is really to be able to discern which of these wonderful new inventions can actually work for you. And, we use it with a variety of patients, not only in standard doses, but microdoses as well. And so having seen the impact of these medications as part of the comprehensive longevity management, and that's kind of what I want people to internalize, that, you can't just say, oh, I'm going to use this medication, it's going to do, or this supplement is going to solve everything for me. It just doesn't work that way, but as part of a structured, comprehensive, personalized approach, we could definitely accomplish a lot. And I think, longevity is all about being vascularly optimized and
Mhm.
so that we can preserve our vital organs and preserve
Yeah.
ourselves.
Yeah. Oh, thank you for being vulnerable and sharing that, Regina, that you're utilizing that medication. I think, I have conversations with patients all the time about them, and a lot of people have, some guilt and shame and
Hmm.
some false beliefs around them, like it's cheating. And I'm glad that you're highlighting the all the benefits of the GLP-1 agonist medications. Thank you for that. And before we wrap up, I'd love to give you an opportunity to share about what you have going on. I know you have a book coming out this fall, and just share about all the ways that you help people and how they can connect with you.
Oh, thank you, Cindy. So, connection is very simple. They can follow me on social media, or our website is holisticcardscenters.com. And I absolutely would love to invite your listeners to keep an eye in November when Longevity Switches, my first book, will get released. Longevity Switches is about finding your own longevity switches that will turn on your longevity. And that's, scientifically based, but also has stories from some of my patients and certain things that, I learned in this journey of cardiology and longevity. It's through both, other experiences and my personal experiences. So I invite all of you listeners to give it a shot.
Super. Longevity switches. I'm writing
Yeah.
it down.
Longevity switches. You can think of it as a light switch, right? On or off.
Yes, I love it. I am definitely gonna pre-order that when that's
Thank
available.
you.
Well, Regina, it's been such a joy, and I'm so grateful that you got inspired by is it your aunties that inspired you early on to
Yep.
become a doctor, and you absolutely have followed in their footsteps of becoming a very powerful and brilliant and wonderful doctor. Thank you for all the work that you're doing and inspiring me as well. And
Oh,
thank you.
you inspire me as well. Thank you, Cindy.
Yeah, thanks for your generosity with your time today.
You got it.
Thanks for watching. If you enjoyed this episode of Rethink Aging, please like, subscribe, and share it with someone you love. For more episodes and highlights from the show, you can check out more videos right here and here. I also invite you to join the Rethink Aging community at caringforthebody.org, where you can find more resources on how to better protect your brain, strengthen your body, and live with purpose. Thanks again for tuning in, and I'll catch you in the next episode.